in the last couple of lectures, we talked about the mineral homeostasis in bone. For this lecture, please stop talking, take this conversation outside. So this lecture, we're going to be talking about some investigation that you do to look at this metabolic bone diseases that we discussed in the last couple of lectures. So these are today's learning objectives. So first, we'll be talking about the bone turnover markers. We mentioned that the bone remodeling process happening as a result of many things. Some of the stuff we discussed was the disturbance in the calcium level, for example, and end up, increasing bone resorption and bone formation, either one of those. So clinically, most of the clinicians don't call this process remodeling; they call it bone turnover, which means that you flip the bone, moving something out and putting something in. So this is the term that you hear mostly when you are in the clinics. So this is basically the bone resorption and formation happening at the same time. So we have different markers that can tell you there's some bone formation happening and bone resorption happening based on how osteoclasts break these matrix and how osteoclasts deposit other material or matrix inside. We classify them into bone formation markers. These are a list of some of them. Bone alkaline phosphatase, we discussed that before. This is what the osteoblasts will secrete to start the process of mineralization. Osteocalcin is one of the associated protein that exists in the bone formation, and also the N-terminal prototype of type 1 collagen and the C-terminal prototype 1 type collagen, which is the PINP or PICP. You remember when we talked about collagen in the connective tissue in the first semester, we said collagen is made of those pro-collagen. So, and then we trim this, we cut the ends of this before forming the mature collagen. So what will happen when you start depositing bone as an osteoid after resorption? You start depositing bone collagen inside, but what will happen is those C and N terminus of the pro-collagen will be released in the circulation. So you can detect this in the circulation through the lab testing, and if you see an increase in the C terminus or N terminus of the pro-collagen, it means that this body is actively depositing some bone inside. Because it's the process to be able to fill the osteoid, you have to have collagen, and then collagen, you have to break the pro-collagen. Once you break the collagen, we see those, chopped ends of the collagen in the blood. The bone resorption markers that we talked about, we said that the osteoclasts will resorb the bone. So they end up actually doing the opposite. You have several markers. One of them are called the C-terminal. I mean, this is short for the C-terminal pterocyte of type 1 collagen, or the N-terminal of type 1, or pterocyte of type 1 collagen. Again, here what will happen? Osteoclast is going to resorb. It's going to be resorbing the matrix either by acidifying the lacuna, secreting the proton ions in there, and then will break down the mineral. This will release the calcium and phosphate, and we can see that in the blood, but also it's going to break the collagen. So when you break the collagen, also you're going to be cleaving this into two chops, and then you end up having the two ends of the collagen. Then you can detect. So the blood testing with this, when you look for bone turnover markers, it can tell you are breaking the bone or forming the bone through what you can detect in the blood. Most of the diseases, you have either high bone turnover or low turnover. These are not those used diagnostically. Let's say, if you have an increase in bone resorption markers, in this case, it doesn't mean you have osteoporosis. It means there is imbalance, but doesn't mean that it diagnoses something differently. It just detects what's happening. And most of the time, you can find also some bone formation marker happening in the same time. So at the end, you can actually tip the balance, but the presence of one of those markers is not really diagnostic as a certain disease, but rather telling you something going on in the bone. That your bone is really working hard for some reason. Then you can start, what is causing this? It's, for example, if you have hypercalcemia, you end up reserving a lot of bone, but you will see high bone turnover marker because resorption will increase, but also formation will increase. Maybe it will not be catching up and you develop osteomalacia, but it doesn't tell you exactly what's going on. So this is just part of a routine testing you do to see what's happening in the bone. So, but doesn't give you a certain diagnosis. So These are some of the resorption markers, the CTX and NTX, and the TRAP also, which is some enzyme that the cathepsin K as well, that we talked about resorbing the osteoclast, the bone by the osteoclast. So how we do that clinically, other than also looking for something that help you with the bone turnover marker, telling you what the bone status, but also most of this used for the follow-up of the treatment. Now we have a patient with osteoporosis, give him bisphosphonate, let's say. Now we know that osteoporosis, you might have high bone turnover, increase. But if you give him the treatment for a year or 6 months, did you do anything? Then if you look at the bone turnover marker and I see some difference, you slow down the high bone turnover, and it means the drug is effective. So this is something that the clinician will do after starting the treatment to make sure that we do something to the bone rather than there is no effect happening. Especially with some of this action, which is called the withdrawal. The bisphosphonate or denosumab or other drugs, when they use it for treatment like osteoporosis, it's long term, they use it for a long time. But they try to give them what we call a holiday. Can we stop for a certain time and then the patient will be okay, or he will go back to the same process. So you end up giving this holiday, but then you have to see what's happening with this bone turnover markers. Are they going to stay stable like the treatment, or they're going to be increasing back again and everything? Then I have to put him back in the cycle. So usually if you see those patients, they go in cycles, 2-3 years or something, and they give a holiday, and then another 2-3 years. They all follow that by the bone formation, the turnover marker, and say, okay, if they're going to go high again, I have to give them something back, and make sure that things are stable. Again, things like the hormone replacement therapy also can give you some effect, and then you have to follow those up with the bone turnover markers. So, again, mainly they use the PINP detection for response of anti-resorptive treatment, and this is just the graphs of some publication comparing two different drugs. These are both different types of bisphosphonate, and you can see these are the bone turnover markers. You can see they're very high, starting with this on all these patients, and then after you give them 6 months, they drop. And then you see how long they can stay without the treatment, and you maintain there. So you stop the treatment, and then you can see one of them is better than the other in inhibiting those bone turnover markers. So what you need is the stability. Can I keep them without a drug and you can stay low, or they will go back, jump again? So again, most of these drugs have some effects, and when you keep any drug for somebody for several years, they try to stop every once in a while. So most of this time you see all these graphs when you talk about pharmaceutical companies, especially if they release any drug, they always have to release this data to tell you the drug is effective, and even if you stop it after a while, it stays in the bone. Again, bisphosphonate, I told you, will get trapped in the bone matrix. So it is, even if you don't give the treatment, they still exist in the bone, and then will be effective against osteoporosis. So how we diagnose bone diseases? Most of the time with osteoporosis, we do what we call bone mineral density. Bone mineral density is basically you measure the amount of mineral inside the bone, which is basically the hydroxyapatite. If you have enough hydroxyapatite per square centimeter of bone, we have certain measurement that tell you the quality of this bone is good. This will give you also what we call the strength and density. The whole idea of actually the osteoporosis and these diseases with the bone mineral density is, are you more susceptible to fractures? Who cares actually what the bone will look like if nothing's going to go wrong? The fracture is the problem, especially the older you get. Fracture in somebody who's 75 is a big thing. I think you probably can die from embolism and stuff like that more than they need a fracture. So one of the things, plus also this ability they can move, and then they need help the rest of their life and so on. So the better the bone mineral density, the chances of fracture is much less. So all what we try to fix, there's things about calcium and so on. So it is the most important predictor of fractures. If you have low bone mineral density, it means you might fracture easier than compared to somebody else. It's a surrogate parameter which assessment does not differentiate pathological causes, which means I don't know what the cause is the bone mineral density low, but I know it is low, so I have to figure out also the things. And like, again, you can look at bone turnover markers, and look for something else, calcium level and so on. The bone mineral density is an aerial, which means basically you have to be careful because you're measuring in certain area. So if you take a bigger area, it's going to be more amount. So you have to be consistent exactly how well. So it's a standard measurements. So every time you get the bigger area, there's more mineral. So yes, if we're going to count the students, every time I take half the class, there's going to be more students than if I take only fraction of the class. If course, because the distribution is supposed to be even. So the machine we use called the DEXA, or the dual energy X-ray absorptiometry. This is an X-ray machine. You see it now. I think you've seen it. Habib Hospital, they always announce that they have the DEXA machine to measure the bone mineral density. So this is the gold standard of diagnosing osteoporosis. That's the machine accepted by the FDA. If you use it and you see some measurements, you can tell this patient you have an osteoporosis or not. So it's a dual X-ray. It means this is how it looks like. This is General Electric, one of the main companies that make. I'm not advertising for them, but this is most of the company. So it's an X-ray machine. The patient will sit there and then they get exposed. It has dual sources. Somehow the physics work, and then you get measurement of this density inside. Most of the site we look for in these patients in the lumbar spine, as we said, because it has the most trabecular bone usually compared to the size, the femoral neck, and the forearm. It's easy because also these are the most common sites for fractures.
So density is measured for which part of the bone? I'm assuming it's the cortical bone. Like, won't different areas of the bone have different density?
No, you see, they measure, the sites are different. Get lumbar spine or different. No, with this one it's aerial. It means everything the beam will go through will measure. So to measure actually the density, if it is the cortical, let's say the femoral neck, it goes through the cortex, the trabecular, and the cortex on the other side. So it measures density in this area. So that's why it's called aerial. There's something else that measure inside only. So in this case, if you have the lumbar spine, let's say it's mostly trabecular, not cortical. But if you go to the femoral neck or the humerus, the radius, you have some cortical bone as well. So it depends on the site. That's why usually they measure multiple sites. They don't only do the spine, usually take multiple sites. And these are the most sites for fracture. For those elderly people, first if you have osteoporosis because of their weight, the vertebral fracture because of the trabecular loss, but also any trauma, people when they usually fall, they support with their hands. So they fracture here at the radius or the ulna, or when they you fall on the ground, they fracture their hip. Yeah, for the neck.
Dr. We said for the aerial bone mass density, we said it depends on which area you're measuring your bone density, right?
Yes.
But wouldn't the bone density be equal throughout the whole bone?
No, it's amount. So if you have an area that has the thicker cortex, it's going to be more. You see, and the density of the bone also varies because the cortical bone is much denser than the trabecular. So if you have a compact bone, you have a lot of bone matrix that mainly are quite condensed, and then the distribution of the mineral is supposed to be similar, but it's the amount of bone itself. That's why it's called aerial. It's not a volumetric. It's aerial. The bigger the area, like the table here. If I take this table, the density of the wood is this much. If the table is thicker, even a small area, then it will be more wood. Correct. So the bone is the same with the mineral density here is the same. We're not looking actually. We're assuming if you have. This assuming also you don't have any mineral deficiency because of other diseases. I mean, we have some measurement for what's normal. You see, we'll talk about the standard measurements. So it was actually the clinical practice when the DEXA was first approved. The measurement in the United States by the Food and Drug Administration was like in 1988. And 6 years later, in 1994, the WHO, the World Organization, considered this as the standard way of assessing bone mineral density. And the way we diagnose what we call osteoporosis. So there's something called T-score. There's certain, area and measurements that we'll talk about. But the development of this machine and also the ability to treat osteoporosis in 1995 with the bisphosphonates was really, we call it the modern era of osteoporosis management. Before that, nobody knows what to do. We can't even detect. People just fracture, and they're older, just old people. But now we develop this technology, and then we find a way how to standardize this. Now we can tell you go use this machine, you get this score. We know if you have osteoporosis or not. That's why it's now become way common practice in medicine. So DEXA, as said, for essential for diagnosing osteoporosis, monitor changes in bone density. This is what you get. You go to the radiologist, they make this measurement. Let's say they're going to be multiple vertebral bodies, and then you get expect some number bone mineral density, and then they give you some scores here that we'll be discussing in the next couple of slides. So the main thing is what we call T-score, which compares individual bone mineral density with the average peak bone. This is the way we actually measure the score for osteoporosis. Usually for postmenopausal, it's been over 50. So we give them a score. If you have a score of -1 or above, you consider normal bone. If you have -1 to -2.5, this is called osteopenia, a weaker bone, which is more susceptible to fracture. If you have a score of -2.5, this is osteoporosis for sure. You are diagnosed with osteoporosis. What does it mean? The T-score here, it is, we look what we think is the optimal or peak bone mass of your age, and then we compare that to you when you are 50, and we see the changes. So if you have a score, let's say normally at the age of 25, you are 1, and then you start deteriorating over time until you develop osteoporosis at a certain time. So what we give here with the T-score is comparing what's supposed to be the peak mass of your middle age or average age. So here is just a graph. The low bone mass would be between -1 to -2.5. 2.5 is the gold standard. Everybody accepts this across the world. The DEXA score with the T-score, then you get 2.5, you are osteoporotic. Now there's something called the Z-score. The score is a little different because in this case, you're comparing the individuals. So they compare Nasser with the guy next to him, which I don't know his name, the same age and 6, and we see who's actually better than the other. So, and we can see the changes in that. It's supposed to be standard, and then, okay, Nasser is a little bit higher, and he's a little bit lower, or the other, he's a little bit higher, a little bit lower. So, but the other one is that the T-score is comparing to the average age and the time and what happened over time. So the Z-score is basically not considered as the gold standard when it comes to osteoporosis, but give you some, with your age, you're not supposed, let's say Nasser is a little bit lower. This is not normal for him, so we have to investigate what else. It's not osteoporosis, there's something else is going on. So we have to investigate furthermore. And the score here is a little bit different. -2 differentiate between low and high or normal. So again, there's just some data that show you if you compare with these different drugs, you can actually increase bone mineral density with using this particular drug, the alidronate versus exidronate, which is blue here, and this is significant difference. You can see the improvement in the bone mineral density changes over time. So they usually have a baseline and you measure every 6 months, and you can see the improvement. To just summarize, this is what we did with the bone turnover markers, bone mineral density, and how they complement each other. So there's other investigation which is less commonly used, it's more expensive, and things like quantitative CT. This is the 3D image. This is, if you see the word here, volumetric bone mineral density. This is what you're talking about. Here, because of CT, I can define exactly, I'm going to measure the cortical or trabecular bone, because I control where the beams will go. It's an X, it's a CT scan. You basically slice the bones and then you reconstruct the images. But can precisely put it where I put. So I can put exactly, this cube is a 3D image, and then I put it inside the area where I want to measure. So if I want to trabecular bone only, then I can avoid all the proteases and see where it is, and then measure that specifically. The problem with this, it is, radiologists always worried about the exposure to radiation doses. So because any CT takes longer time, so you get exposed to longer time. So they don't want to repeat this. And they said, no matter what, even if you give long time between the scans, it's cumulative. Every time you scan somebody exposed him to radiation, it will stay. So that you always have a risk of this. But the DEXA scan is way less. It's similar to the regular plain X-ray, basically. But CT scan way longer. So, but this you can get a lot of details. So there's a limitation of exactly if I want to see trabecular bone, yes.
What kind of cases would you want to see trabecular, not cortical, and the opposite?
No, it's not what kind of cases. It is usually what kind of disease. Osteoporosis usually affects the trabecular bone than cortical bone, unless in older ages or somebody has been extending. So the accuracy of this is much higher. But again, the exposure does it make a difference in the treatment? Till now it doesn't, because you're going to do the treatment regardless. So things like that you have to weigh. Which one is really important. Somebody frequently fractures certain areas, you have to look to see really, because sometimes abnormality, not the amount that you see in mineral, sometimes the structure itself, the architecture of the trabecular bone is different. Yeah, so that's the big more details when it comes to this. So it overcomes the limitation in the use of aerial bone mineral density, which you get with the DEXA. So these are the images we get. So this is the radius and the ulna, and then you can see. And you can, this is the reconstruct. I use this machine a lot, so I know exactly what's going on here. So you can see the cortical bone, and then this is the trabeculae 3D structure. And you can say, okay, I want the 1 centimeter by 1 centimeter area measured. Then you quantitate everything inside to give you very clear details of what's going on. You can see the images here, and then this is just the software will do all this reconstruction for you, and then, okay, you can count, you get all this data. The peripheral quantitative computer tomography, and you can see, I can see the number of trabeculae, how much of those connected, how thick they are. There's a lot of data that this machine splits, and then the number of trabeculae, their degree anisotropy, how they change from plates to rods, which is making them weaker. All these details can give you exact, clear idea of what the architecture of this trabecular bone is. Now, especially with the artificial intelligence, I mean, I haven't done any research since I came here 4 years ago. But I know now the AI, it used to be the software, and then you start analyzing your data without really knowing. I mean, just split this number and try to compare between the humans. But with the AI, you can now analyze for you and give you an idea, I need to look for this, and this will, so the analysis will become more sophisticated, and you can get more data rather than what's built in the software. But again, using ChatGPT, it will give you data, but the problem with the ChatGPT, it doesn't have the background that the software built. So you have to buy the software because software will build certain assumptions about what the normal structure is supposed to be, and then the AI can help you with this. But if you put it to, and some people do that, not with this one, other things. And you put the ChatGPT, remember that ChatGPT will try to collect any information that you may gather online that might not be related to what you're talking about. And it will give you a number, and if you have no idea what's going on, you believe it. So artificial intelligence is good, but you have to be really clear about what you're going to use for the analysis. Don't just put, because they will always spit some data for you, areas, these are numbers and thousands of numbers, and what does it mean? It might not be the right thing, it can be just putting. So it is still developing some of this, the deep learning techniques and artificial intelligence in analyzing. This of course applies to many things, X-rays and MRI and so on. So you have to always be careful exactly what it is. Those software they built around these machines, they have certain assumptions of what's the average of this, and they have information stored of, for this age is supposed to be this numbers, and this age is supposed to be this thickness, and this connectivity density, and so on. So the AI is not going to realize until you feed him inside the software. That's why the companies use this AI to help them with the analysis of the software, not to use that on your own. Magnetic resonance image is also something else. It's also not an ionizing technique, which is good because you can do that frequently without, feeling that you're exposing the patients to, hazardous radiation. Yeah, and then they give you more of anatomical size, but the clarity and the accuracy depends on the yield of the image, high enough resolution. With MRI, we cannot go as high resolution as the CT. There's still a limitation to how fine the MRI imaging can be, especially in the bone. The scintigraphy, the radioisotope, which is the bone-seeking radiotracer, you can inject some of those radioisotopes and will go to certain sites where they have activity based on what you do intravenously. This is the issue that we have the war in Iran. US doesn't want Iran to have any of this. Iran said we use it only for medical use, and America said no, but also you can use it for bombs and stuff. But these are the same principle, radioisotopes. In the US, some universities actually enrich these materials. It's not something that you can do. But anyway, this is of course more invasive, this more, because you get people exposure, you call them hot. If you inject somebody, if it's going to radiate this kind of radiation everywhere. So, but most of the stuff that used in the human is very short life, within hours will disappear. But you can actually use them, and some of those are even new one, like this specifically, let's say the alpha V beta 3 integrate. These are the sealing process by which osteoclasts attach. We can actually target this with some radioisotope. Can you imagine this? And this will label the cell, and this will emit radiation when they join each other, and then we can trace exactly how those clusters are actually making the sealing zone or not. Because we said if they do the sealing zone, we know they can resolve the bone. So we can get that sophisticated. Of course, expensive. Not everybody can do. Not everybody have this facility. But just to say you how far can we go with this techniques. So you can even look at the cells. Not really used, of course. Usually experimental is very expensive and very, very tricky. Help with the diagnosis, yes. A lot of this time things are osteomalacia. I mean, a lot of this stuff you can actually see the accumulation at certain sites where the activity happened when you inject, and these are what you get with radiodissolve. These black things, when you pick it up a lot, it means there's a lot of remodeling happening at these sites. With the radiodissolve, in certain disease, you have to see how far this is, and then it can be used. Now, histomorphometry. We always talk about the histology, which is basically you can decalcify, you can take the stroker and then punch a hole inside the iliac crest and then weigh all the way to the other side and collect these samples, bone biopsy. When you look at this was the way that we diagnose any metabolic diseases before all these imaging techniques, and you can get a lot of data. Again, the same that you get cortical width, the cortical porosity, and trabecular number thickness, so on. So what is this? Anybody read? Yeah, this what kind of bone?
Cortical.
No, trabecular bone. Lamellar, any bone with lamellar as long as mature, that's the point. Lamella, you can see the lamella here, you can see the layer. Whether it's cortical or trabecular, at this stage you should know this. Any bone, but the cortical bones will be osteonal. This is trabecular bone. Lamellar is mature. The red is immature, it's osteoid, it's special stain. So this osteoid bone, and this is trabecular.
Dr. why can't it be outer circumferential lamella?
And it's going to be outside the tissue here. You see fat outside here, and then inside marrow here. No, it's not going to be. Plus outer subscription, outer circumferential usually surrounding osteum, correct? So there should be osteum somewhere. There's nothing. We cannot just separate the outer circumferential lamellae, correct? It's part of the cortical bone. So again, you have to think of the histology as the organization of the tissue, not the individual. You have to see the whole thing together. I told you that's why you have to always look with the lower magnification. If you go to 40x, which is most of you do, you're losing the picture. You don't know how things are organized. The pathologist diagnosed at 5x, maybe 10. The pathologist who look at 40x is looking at something different. Looking at cellular structure. I told you that. The histology is about the pattern, how things are arranged. I told you that in the very beginning. Not about the 40x where you can see only 2 cells in the field. That's why when you look at the growth plate in the lab yesterday, or you or somebody else, and you have the images focusing at 40x, you only see 5 cells, and then the difference between the reserve layer and the proliferation, they look the same. Look at the pattern, look at the 5x, they look clearly different from each other. So this is histology. So here it is. Yeah, so this is the trabecular bone, and they can see with this, you can see cells on top, osteoblasts, and this osteoid, just special stain. But this is what you get from the sample, exactly what's going on. So you can see here another image. There's something also, this is called static histomorphometry. There's something called dynamic histomorphometry, which means I can label the patient with something, fluorescent label. Usually you give them tetracycline or some stuff with tetracycline, fluorochrome label, and this will deposit what calcium is. So it's not stained, but I inject this patient or give him actually tablets of tetracycline. Tetracycline will bind to the calcium. So every time you mineralize a surface, this surface will light up. So I give him another label after 2 weeks and then another surface. And there's a way to see how much of the bone is forming over time, which is also how much of this mineralized. So this is unmineralized. But if you give them the label with the label will actually bind to the calcium. If you see more of this surface is mineralizing, it means this will eventually mineralize. But if not, it's going to be all black. It means this is going to be staying osteoid. So you can see all these dynamics. They call it mineralizing surface over bone surface. So if you look, this is a dark field actually. It's fluorescent microscope. All this area here is trabecular bone. And you can see certain surfaces are white. There's no deposition of calcium. It's not mineralizing. This surface is mineralizing at 2 time points which you give, and this one at what time, and others are not. So this is called dynamic histomorphometry because I can see things happening. I give it every week or 2 or 3 weeks. and get the biopsy and see what's happening inside the bone, either through the deposition of osteoid bone in the static morphometry, but dynamically by looking at the floor core. Yeah.
So what does it bind to? Like what is present in the osteoid that's not present anywhere else for it to bind?
No, the calcium, because this bind, the label will bind to the calcium.
Like free calcium? Active
No, the calcium. We mineralize the bone, we deposit osteoid, and then mineralization happen, correct? So if mineralization happening in this site to pick up the label.
But isn't there also calcium in the bone? Or does it not pierce the bone? Isn't there also calcium in the bone? In the trabecular bone?
You mean inside here?
Yes.
Yeah, but I mean, usually the activity increases when it starts putting in it's much more active. So there's something, but you cannot pick in the label. Because the activity of the calcium binds in the slime and deposit really heavy during the mineralization process. After that, it distributes between the lamella. You said, you remember the hydroxyapatite when it starts forming and spread, then it doesn't get the labels as much. Yes.
Dr. Yusuf, the calcium bound to phosphate forming hydroxyapatite.
Yes.
So how will it bind to? How it's bound to calcium? It's bound to phosphate.
No. The label binds to the calcium when you give it. The free calcium. So the free calcium will go be deposited inside the bone.
Free calcium?
Yes.
The calcium or the calcium bound to phosphate?
No. Hydroxyapatite is what? Calcium and phosphate together. Where the calcium is coming from? The circulation. So the circulation. When you give this label, it binds to the calcium and the calcium will be light. So anytime the calcium will go, it's going to go to find the phosphate and deposit in the hydroxyapatite form. They form the crystals later.
So it binds to the calcium before it's bind?
Yeah.
So
It will
free
bind
calcium-
and it will
free
go.
calcium from the circulation?
Yeah, because we give it, it's oral or injectable. You give it to the patient, and then this drug, it's actually tetracycline, is an antibiotic, but has this. Yeah, and by the way, the tetracycline, do you know the tetracycline is an antibiotic? Do you know, we don't give it to the kids.
For
the
produce
breastfeeding.
golden or yellow teeth.
Yeah, because of this, because they feel worse. So we give it to the kids, and the kids building still their teeth, and then the calcium deposited also, and then the calcium is yellow. So their teeth looks yellow, that's why I don't give it to the people who still developing their teeth. So things like osteomalacia, look at this, that will show you the X-ray before and show you what we call pseudo-fracture because of lack mineralization. Look at this. All these red surfaces are unmineralized, osteoid only. So this is a lot. You compare it to the normal. Normally, if you have a biopsy like that, it's going to be a small area like this only that's not mineralized, but you see with osteomalacia, you can diagnose it. Anyway, so for this, actually, it's quite invasive, and this is another, you see the difference between osteomalacia here and the normal. All these reads are osteoid bone, but you can see normally it's not that much. So you can diagnose disease like that. Now, we can get a lot of information with histopathology, but because it's invasive, and the physician said, I don't need to take the biopsy because a lot of those imaging and blood tests can help you with the diagnosis, so I don't need to do much histopathology. But so the clinical limitation is limited now with certain diseases that you can use this. But still, histopathology is a must for anybody developing a drug to the bone. For the safety and effect, and actually showing the mechanism of osteoblast, especially because you can see osteoblast and everything, anything that you can see and you can measure through. So that's why anything that's going to be based on the bone as a target, then you have to give this data before any approval from the FDA. So again, it's just summarizing all this imaging, histopathology, the QCTs, and the PET scan, MRI, DICS, and so on. Now, I put a couple of questions because I know everybody will be worried about the exam. Somebody can think about this for a minute and tell me what's the answer. So, you don't have a TBL question, but I said, okay, maybe I can help with them giving you a couple of questions so they know what to expect.
A or C?
Take your time, 30 seconds, and somebody can volunteer to read the question and answer the question. Yeah. No, just give everybody just 30 seconds and then. Yeah, just take it down. This is like an exam, TBL, whatever you do. No, I don't think so. You mean I use it before?
Like We didn't have cell biology and
I
TBLs.
didn't say biology. You didn't ask me, which is good because I hate this TBL. It's nothing. You just come there and stay for 2 minutes. Reorganize this thing. No, I'm serious. I try to avoid this TBL. It's a waste of time for me. I'm sure for you it's not. Okay, Abdurrahman, you ready? Take the microphone so I can hear you.
صوته بينسمع عادي.
لا not.
A 6-year-old child is evaluated for recurrent fractures, delayed tooth eruption, and increased bone density. Bone biopsy shows numerous osteoclasts attached to bone surfaces, but the resorption lacunae appear poorly developed. Genetic testing identifies a loss of function mutation in CLCN7, which encodes the CLC7 chloride proton exchanger. The HET-based proton pumps are still present, which consequence best explains the defective bone resorption in this patient. I believe the answer should be C, failure to maintain electroneutrality in the sealed resorption compartment, limiting sustained proton secretion and hydroxyapatite dissolution.
People agree or disagree? Yeah, so that's correct. So the question is long, but if you just know the key here about this, so does it do anything with the reducing intercellular proton generation? No, no. So again, this is similar to there's only one answer that fits, really, if you know the information here. The problem, a lot of the students, they get confused with the reading the question. Similar to what happened actually with the growth plate, 6% only. But try it, there's only one answer that fits. It just people get confused. You have to see the key here. The key here is basically what this CLC will do. And I told you exactly this is the very good Abraham. Thank you.
Thank you.
So there's another one here. Somebody can read it. You're famous now, huh? Yeah, somebody else. Right. Give him the microphone. Can you throw the microphone on him?
A 14-year-old patient presents with recurrent painful swelling around the hips and shoulders. Imaging shows large periarticular calcified masses. Laboratory studies reveal hyperphosphatemia, low fractional excretion of phosphate, and elevated circulating FGF23. Serum calcium is normal. Genetic testing shows markedly reduced renal coltho expression, causing resistance to FGF23 signaling in the kidney. Which normal action of FGF23 is most directly impaired in this patient?
Can you read all the answers and then tell me which one?
Okay. ACE, suppression of renal 1-alpha hydroxylase activity, reducing synthesis of 1,25-dihydroxy vitamin D. B, downregulation of
Sodium phosphate, yes.
Sodium phosphate and sodium phosphate 2C co-transporters in proximal tubule phosphate reabsorption. The answer is C. C, stimulation of 24 hydroxylase activity, increasing the degradation of active vitamin D metabolites. D, inhibition of PTH secretions due FGF23 signaling in parathyroid cells. No. Reducing of intestinal phosphate absorption secondary to decreased calcitrol production.
So the answer is one?
B.
B. Everybody agree? Anybody disagree? No. Why it doesn't inhibit action of PTH secretion? We said it doesn't inhibit. I just want to include. Can you speak about why it doesn't inhibit? I said it inhibit PTH.
Yeah, but we talk about the reduced renal clotho, not the parathyroid.
No, it's something else.
It's not related.
It's not related.
It's not for the parathyroid cells.
No, it's just you get it for the wrong reason. I mean, there's one clue here, one key. It's close.
Low excretion of phosphates.
No, you get it. I mean, you get the wrong answer, but you get the right answer, but for the wrong reason.
Serum calcium is normal.
Serum calcium is normal.
Serum calcium is normal.
No,
In the
it's
kidney?
simple. Back.
What was the core receptor for the?
Yeah, FGF doesn't exist.
Downregulation.
anything the FGF can do here, it doesn't do it, because it only work when the clot is there. You see? So yes, it should inhibit PTH, but only through the presence of the receptor. Excellent, thank you very